So I would like to welcome Professor Laura Rienzi and Dr. Ludovico Parmigiani for joining us today. Also welcome to our audience. We have an exciting program today for the next 90 minutes. It is on the subject of vitrification, and I'm honored to introduce now at first Professor Laura Rienzi. Professor Laura Rienzi is a senior clinical embryologist and laboratory director at the Genera Centers for Reproductive Medicine in Rome, Marostica, Ubertide in Naples in Italy. She obtained her biological degree magna cum laude at the University of Rome, La Sapienza, and her master's in reproductive medicine at the University of Padua. Laura was elected president of the Italian Society of Embryology, Reproduction and Research in 2014 and is now adjunct professor in biotechnology in assisted reproduction in the Faculty of Biology at the University of Urbino. She is author and co-author of around 200 articles, reviews and book chapters, and has a passion for sharing her knowledge, which we will be able to enjoy in a few minutes. Laura was invited to speak in more than 300 national and international scientific meetings. She has also held editorial positions, associate editor of Human Reproduction and Human Reproduction Update, editor of RBM Online, Fertility and Sterility, and Focus on Reproduction. Laura was chosen by the World Health Organization to be author, along with top international experts, of the WHO manual containing the guidelines on the treatment of infertility. So I'm honored, Laura, to have you today here, and we are looking forward to your presentation.
Thank you so much for this very nice introduction. I'm very happy to be here again to talk about one of my favorite topics, which is vitrification. So I will start to share my presentation. Vitrification of oocyte and blastocyst, theory and practice. I will try really to cover what vitrification has meant for our field, especially in the lab, and how this technology in the lab has really changed the picture and have given so much opportunity also for the best treatment of patients. So this is my potential conflict of interest, nothing related to this presentation. I'm member of a scientific board of ELISA, and I'm going to show you what it means here. What it is here. So to have an efficient cryopreservation program for oocyte and embryo, it's mandatory in IVF. An IVF center cannot work and should not have, I would say, the faculty to work in IVF if you cannot guarantee an efficient cryopreservation program. And today it's an efficient vitrification program. And why? This is so important because it will offer so many opportunities for the patients, for the gynecologists, and for the lab itself. So first of all, if you are able to cryopreserve in an efficient way oocyte and embryo, you will enhance the cumulative live birth rate per cycle. And this is really very important. We have to use all the cell available for the patient, if the patient is willing to, and give a chance to rescue all the supernumerary embryos to fully exploit the chance of live birth of a given cycle. But it also allows the systematic application of elective single embryo transfer. You know that multiple pregnancy in IVF is one of the major risks of our technology, especially now that we are dealing with a population of patients which is more and more difficult and more with advanced maternal age, with more obstetrical risk. So it's very important to work for a systematic application of single embryo transfer. And this is possible only if we trust on our cryopreservation program, because if a patient has 2 embryos and transferring one and cryopreserving the second one means to lose potentially the second one, gynecology will be more prone to transfer 2 to guarantee that, to fully exploit the poor chance that the patient has. But if the gynecology trusts, the clinician trusts in the cryopreservation program, knows that the second one will not be lost, but will be available for the patient for the second transfer, of course, we are going all together to move to single embryo transfer. So you see how much a lab technology, it's important to reach the gold standard in IVF. It's not only a question of the choice of a clinician or a choice of a patient, it's a combination of quality of the lab, choices, and opportunities. And to cryopreserve embryo, it gives not only an increase in efficiency, but also an increase in safety. And going on with safety, today, because we are able to cryopreserve the embryo so well, there is no risk anymore to propose a freeze-all strategy or a cycle segmentation. Besides the fact that it can be a clinical choice, but it is for sure an incredible opportunity in those patients that are at risk, even at mild risk of hyperstimulation. So today we can have sophisticated clinical strategy with different combination of drugs or different induction strategies to reduce or eliminate hyperstimulation syndrome, but this is combined with a freeze-all strategy, and this is possible because we trust the lab and we trust the cryopreservation. So agonist induction is possible in an antagonist cycle, and it's so much used all around the world to avoid hyperstimulation and to better stimulate a good responding patient, only because we trust the cryopreservation program. So you see how much vitrification has changed everything in IVF. It also gives an incredible opportunity for the lab, because if you are in a freeze-all strategy, you have a lot of time that you can be invested to better assess the embryo quality. You can look back to your time-lapse video. You have time to elaborate the data, to accumulate data, use new algorithms or new possibility to combine the data, but also use genetics and much more that is coming up for the future. So time is necessary to have to make a better assessment of the embryo, and vitrification offers this possibility to stop the time, make all the analysis, and come back for the transfer on the next month. So opportunity for the patient, opportunity for the gynecologist or the clinician, opportunity for the lab. But it's also extend the population of patients that can access to the treatment. And this is for me even the most important side. I mean, one of the most important sides. So imagine that today we can offer fertility preservation because we have a good cryopreservation program, in particular the vitrification of the oocyte. It means that patient that has to undergo an incredible therapy for oncology, whatever is gonadotoxic, can preserve the oocyte before going through that difficult journey. So incredible opportunity for millions of women all around the world. It also offers a possibility to cryopreserve oocyte, to postpone pregnancy. I'm not happy about a society that is postponing pregnancy, but it is a necessity in many, many social environments, and we cannot hide this problem. Women are facing pregnancy or facing the desire of a family much later in life. And our ovary are the same of 2,000 years ago. So ovary are not evolving as fast as the society is to allow to preserve oocyte and give an additional chance to women all around the world but cannot afford the pregnancy earlier in life. It's really another incredible opportunity that comes from the lab, from our capacity to vitrify the oocyte. And last but not least is egg donation. Of course, in a population of patients that are facing IVF so late in life, we have unfortunately a large population that will need egg donation because of premature ovarian failure, because of the quality of the eggs, because of the accumulation of aneuploidy. We know perfectly that there is a big percentage of patients that needs egg donation after a difficult journey looking for a pregnancy. And it's not, donors are not available everywhere. Especially like in Italy, we can do egg donation, but we don't have donors. But today, egg donation is available in our country for thousands and thousands of couples. And why? And because we are importing vitrified oocyte from banks from other countries where it is easier to find donors. So again, because of vitrification, patients can access to this treatment in their own city, in their own country, with their own gynecologist. This is so important that the lab technology has made available technology to patients more accessible. I'm so proud about this, and we should all be. So after this big introduction about all the possible application of vitrification, I would make my first claim: vitrification is a game changer in IVF in general and in the IVF lab. Is it proven? Many people say, we need randomized controlled trial to prove that one technology is efficient or not. I would say that there are very few randomized controlled trials comparing slow freezing and vitrification. And it is not because we are lazy or we don't want to work on this, but because it was so much self-evident that vitrification was more efficient, that very few groups spend their time, their energy, and the difficulty in doing a randomized controlled trial. Sometimes things are self-evident and we should accept it. In fact, in 2015, when I was involved in the WHO group for making guidelines in IVF, we realized that there were no meta-analysis, no systematic review comparing vitrification and slow freezing. So we decided, all the groups, to make a systematic review and a meta-analysis of a few randomized controlled trials that were available in the literature. And it's funny because when we submit the paper, most of the reviewers were saying, oh, we don't need this review, or we know that vitrification is better than slow freezing. Self-evident, but at the end of the story, there was not a paper describing the superiority of vitrification. So anyway, the paper was accepted on Human Reproduction Update. And it's also funny that the evidence, if you look to the statistics evidence, it is the conclusion is data available for randomized controlled trials suggests that vitrification and warming is superior as compared to slow freezing with regard to clinical outcome, low quality evidence, and cryosurvival rate, moderate quality evidence. So it's not even a strong evidence because of the low number of randomized controlled trials. So not a very high quality evidence, but in everyday life, we know that is a very high quality evidence. So now let's see to what we have in the literature. So we had different studies comparing slow freezing and vitrification. And it was very difficult to accumulate them because they were looking to different stages of development. So as a biologist, I would say that to mix 2PN stage, cleavage stage, and blastocyst stage is not the best way. But because the evidence were there and the study were not so many, we decided to accumulate. And if you look, this meta-analysis, this is the number one means no difference between the two technology. This side is in favor of slow freezing. This side is in favor of vitrification. Although we were mixing different strategy, different countries, different approaches, different vitrification approaches, look, it's very rare that you find a meta-analysis where all the study basically were on the same side, significantly on the same side, so in favor of vitrification. But what was shocking for me is that the survival rate at any stage of development ranged between 88.7 and 100%. 20 years ago, I would never have believed that this would be possible, to guarantee something higher than 90, as a mean 96% survival rate for any stage of development from 2PN to blastocyst. Wow. Young embryologists find it normal today, no? Because it's more than 10 years that we're using vitrification, and we believe that cryopreserving embryos is so easy and you have such a high survival rate. But for us, that started, unfortunately, in the 90s, we used to have 50 to 60% survival rate. It was so stressing when I had to warm a nose, to tow an embryo. I was so stressed to say, oh my God, let's hope that it's going to survive, and how it's going to survive. All the cell partially survive, what I'm going to say to the patient. This stress has disappeared from our lab completely because it's survival and it's 100% survival and all the cells survive. So incredible improvement in this particular part of a procedure. For oocytes, we have decided to treat oocytes in a separate way because oocyte is completely different from any other stage of development. First of all, when you deal with embryos, if you decide to make cryopreservation in the morning, in the afternoon, in the evening, the day after, the embryo will continue growing in your incubator, and it will not make such a difference for it if you decide to do it at 2 o'clock in the afternoon, at 6 o'clock in the afternoon, the morning after. So you could really choose when to cryopreserve because the embryo was growing in the lab in the meantime. But for oocyte, it's completely different. If you decide to vitrify an oocyte for fertility preservation, the oocyte is waiting for the sperm, is arrested at metaphase 2, is not growing in your lab. In the meantime, you decide if to go through vitrification or cryopreservation. So we had the first big problem, which was oocyte aging. So when is the right moment to go through the vitrification procedure? And the lab, it was a big stress for the lab because imagine it takes a lot of time and you have to use a machine and you have to put all the oocyte of all the patients together in the same moment. You would have different timing for vitrification according to the hours of egg retrieval. It was a nightmare to cryopreserve oocyte with slow freezing. It took a lot of time and we had to synchronize the patient for that. And then the oocyte is much more sensitive, not only because it's arrested and waiting for the sperm, it's not activated, but also because it has a very different membrane permeability, means that the cryoprotectant acts in a different way at oocyte stage, completely different as compared to 2PN stage. So it's not really a problem of size. Everybody claim, but because the oocyte is big, but also the 2PN stage is big, exactly the same size. The problem was related to the membrane permeability, to the meiotic spindle, and to the fact that the oocyte is arrested and is very sensitive to aging. So we had to look at the oocyte stage in a different way. There's a different protocol for the oocyte vitrification, and there's very few studies. Only one study was comparing slow freezing and vitrification, looking to the clinical results. It was in favor of vitrification. This is a very small study, not enough to have a high quality evidence. I agree with you, but we all know that it's self-evident, and nobody would ever do today a randomized control trial sacrificing oocyte in slow freezing as compared to vitrification. So this is why clinical results are of low quality evidence, because there is only one study. And in fact, we don't change the fate of the oocyte by doing slow freezing or vitrification. So we were not expecting that the oocyte would be better than fresh or better than slow freezing when we were applying vitrification. The only thing that vitrification does, but it translates in a better clinical outcome, is that you rescue more oocyte. So the only thing that vitrification was very efficient for, survival rate. So we can use surrogate study to study the survival rate. And these are nice studies looking to sibling oocyte. So at that time, between 2009 and 2014, we were using sibling oocyte, means the same oocyte from the same cohort was splitted, half frozen with slow freezing and half with vitrification, to see with the lower confounder possible, the same cohort of oocyte, if the survival rate was better. And as you can see, all the studies were reporting a better survival rate with vitrification as compared to slow freezing. This is why here the evidence is stronger. So you have a better survivor. And because they survive better, not because you change the quality, but you just have more oocyte available, it translates in a better clinical outcome. More oocyte means no chance to find a viable embryo. Now, you would argue that viability is not enough. Viability is, but an oocyte survival is good. But what about the sensitive point, the sensitive structure that are inside the oocyte? One of these is the meiotic spindle. So when you deal with metaphase 2 oocyte, you may be scared, but any manipulation, any additional manipulation you do on the oocyte could somehow disrupt the mediatic spindle, which will end up in an increased rate of aneuploid embryo. So this is, of course, our first thought when we start to work with vitrified oocyte. But luckily, the group of Scott, of Richard Scott in New Jersey, Eric Foreman, made a beautiful study. This study is done on sibling oocyte, is donor oocyte, so very good quality oocyte. And in this case, half of the oocyte were used fresh and half of the oocyte were used vitrified. So the blue bar are vitrified oocyte, the yellow bar is fresh oocyte. And they were so good that they were analyzing the embryo that derived from fresh and vitrified oocyte. And they were not only looking to usable blastocysts to say that there were no increase in aneuploidy. You see that the aneuploidy rate is 16.4 and 17.2, so the same aneuploidy rate. But they were also looking to arrested embryo deriving from fresh and vitrified oocyte. And here I have to say two important things. First of all, that oocyte vitrification were not increasing the rate of aneuploidy in arrested embryos. But secondly, as a biologist, I have to highlight that 64% of embryo arrests will not get to blastocysts, not because they are aneuploid, even euploid embryo arrests. And this is a very important evidence because in our mind, we were believing that an arrested embryo is an unemployed embryo. No. We are two distinct things. Something is to be aneuploid and something is to be a non-viable embryo. And in fact, as you can see here, also in fresh oocyte, you may have viable embryo that are aneuploid, or you may have arrested embryos that are euploid. And this is a very important concept that we have to keep in our mind in general. Okay, to be viable and to be euploid is not enough. We want also to have normal neonatal outcomes. So at that time, we had a lot of study looking for the obstetric and perinatal outcomes, and we had a lot of evidence that there were no increase in obstetric and perinatal outcome when vitrified oocyte were used. And in fact, it ended up that in 2010 and 2011, all the most important scientific society stated that oocyte vitrification was not anymore experimental technology, but could be considered as a standard procedure in IVF. And I'm very proud to say that here Lodovico study, my study, and Anna Kober study were the 4-1 that contribute for this change in the guideline of ISRM, ESHRE, but also ASCO, the American Society for Oncology. So also in oncology, vitrification went in the guidelines of oncology for fertility preservation in cancer patients. Wow. Now, how many oocytes are needed? How many oocytes are needed in fresh cycle? I don't know why for vitrification, we always ask how many oocytes are needed. This is a calculation that we should do for any kind of patient population, fresh or cryopreserved. So Anna was so good, Anna Kobo, in 2019, published on Neuroreproduction, a retrospective study looking to the cumulative probability to have a live birth when you vitrify the oocyte. She made, of course, a distinction between young patient population and advanced and maternal age population, but also between a social freezing and onco patients. So what is her results? Is that if you're in a young patient population, if you have only 5 oocytes, you have 16% live birth rate, which is quite similar of what you expect for fresh insemination. If you have 15 oocytes, you get about 70% live birth rate. And I would say that 15 to 20% is where you get a plateau over 60% live birth rate. Because 100% can never be guaranteed in fertility preservation, our choice is to say that we need a between 15 and 20% to have a very high chance of live birth with this cohort of oocytes in the future, which range between 60 and 70%. In advanced and maternal age, it's much more difficult because higher than 35 years old is completely different if we are treating a 37, a 38, a 39, or 42, 43 years old women. So I think that here we cannot really extrapolate this data to talk to advanced and maternal age population. But for onco patient, it was very important also. You see here we have less oocyte. Why? Not because the patient has a lower ovarian reserve, but mainly because we have less time to make a simulation or to accumulate oocyte for them, for onco patient. So again, the results are very similar. 10 to 12 oocyte mean between 40 and 60% live birth rate. So I would set as to keep the expectation correct, something between 10 and 20, 15 and 20 oocyte to have more than 50% chance to have a live birth. And it's funny because with oocyte vitrification in egg donation program, we had the similar results. 8 to 9 oocyte, you can reach more than 50% cumulative live birth rate with egg donation program. So you see the numbers are similar in the good patient, good prognosis patient population. But vitrification was also a game changer in another condition, which was not successful with slow freezing, which is biopsied embryo. You know, when we used to do biopsy and combining with slow freezing, the results were very low. The survival rate of biopsied embryos with slow freezing was very, very low. You can see here a paper from 1999, but as soon vitrification appeared in our field, we were able to cryopreserve very efficiently biopsied embryos. So I think that the incredible application of PGT for any indication has been possible because of vitrification, because also a biopsy blastocyst can be very efficiently cryopreserved. And this is our study. We have looked to the survival rate of blastocysts, but were not manipulated, but were artificially strengthened, or but were manipulated for biopsy. And what we show is that the survival rate is in all the population very, very high, but the collapse due to artificial shrinkage or due to the biopsy were positive and was positively associated with a better survival rate. So incredibly enough, the biopsy is not affecting the survival, it's even increasing the survival rate of expanded blastocysts because of the collapsing. So here you see a video of the biopsy. This is the technology that we have set with Antonio Capaldo in 2014. So laser shooting and biopsy together. We're not making a laser shooting in day 3 and then the biopsy on day 5. We wanted the blastocysts to expand normally for the biopsy. This is the biopsy procedure, and as you can see, the embryo is collapsed. And on the other side, you see the embryo is collapsed, and this was associated with a better survival rate. This is a video that was provided by Elena and Bani in our multi-center study that we performed with Humanitas. So just a very small laser shooting to induce the collapse of the blastocyst without any extra manipulation was also associated with a better survival rate. So because of this multi-center study, we have started in our lab also to perform collapsing of expanded blastocysts before vitrification. So what we can say? We can say that we have a technology that allows us to apply vitrification before fertilization, during embryo development, at any stage of development up to the blastocyst stage. Now you could say, yes, but you have just told us that vitrification of blastocysts is super efficient between 95 and 100%, while we know that oocytes are more sensitive and the survival rate in the infertile population goes between 80, 85, maximum 90%. So we should only vitrify blastocysts. That's not true. Pay attention to absolute numbers. You need about 3 oocytes to get 1 blastocyst. So when you lose 1 blastocyst, you potentially lose 3 oocytes. So if you make a correction between absolute number and survival rate, you will realize that there is not such a difference. To lose one oocyte is like to lose 1/3 of a blastocyst. It's not for sure that oocyte would have contributed to the blastocyst formation. So I would say that we can apply successfully vitrification at any stage, and it will be equally effective. And this is why we are very comfortable in offering fertility preservation with oocyte vitrification today. Now, vitrification is not easy to obtain. It's not easy to obtain. You have to have very high cooling and warming rate. You have to ensure that. You have to ensure the correct viscosity or cryoprotectant concentration, and also the volume of the sample to obtain this conversion of material into glass without the formation of crystals. And incredibly enough, there are different protocols in the literature, and there's a big confusion. People think that everybody is using the same combination of cryoprotectant. This is not true. You can find in the market a combination of ethylene glycol, DMSO, and sucrose, but you can also find a combination of propanediol, ethylene glycol, and sucrose, or only DMSO and only ethylene glycol. Pay attention, but all the data that I was showing you, Lodovico data, my data, and Akobo data, they all come from ethylene glycol, DMSO, and sucrose combination, and this is the original protocol from Kuwayama. So when you when you decide to apply a technology in your lab, please read the paper, read material and methods, read what is the combination of cryoprotectant that has been used in that study, and be sure that you are going to replicate the same in your lab. So combination of cryoprotectant, ethylene glycol, DMSO. Volume, a small amount of volume around the cell. It doesn't matter which is the carrier. What is important is that you have a small amount of volume, as in this picture, around the cell, big enough not to make the cell direct contact with air, not enough that the cells stick to the carrier. So it has to be not as small as possible, just a small film around the cell. And this will ensure a very high cooling and then warming rate. I'm not going to talk about efficiency and safety. I'm just telling you that we need to be very efficient. Small volume, direct contact with nitrogen is the best way to ensure cooling and warming rate. And to be able to apply this direct contact with nitrogen, we have to find solutions that also ensure safety. And I'm sure that Lodovico will tell you more about how to ensure efficiency and safety in our labs. Now, are we all good the same in performing vitrification? I'm not sure at all, but we are all good the same. And I'm not sure that I am good the same in the morning, in the afternoon, because this is a handmade procedure. And when our hands are involved in a procedure, there is for sure a very high variability inter-operator, but also intra-operator. So we have published this paper on Jovi. This is a video paper. I think it's very interesting because you can really see step by step how we perform vitrification and how you perform, and maybe compare and find good things in our protocol, but better things in yours. Until it will be a handmade procedure, of course, there will be a variability. What is the variability between vitrification operators and different kits that are in the market? After a good training, and we have a very severe training in our lab, as you can see, we could ensure that all operators had more than 98% survival rate. So the cryo survival rate per operator that perform vitrification and per operator that perform warming is quite stable, although the variability is there, but it's quite stable. So we need a big training, and you need also to ensure that the operator is doing enough procedure per month or per week to maintain that quality. What about different kits that are available in the market? If we are talking about the same combination of cryoprotectant, as you can see, they all behave the same. So you can also mix them, and Lodovico will talk about this according to what is available in the market. Now, another funny story. is about the duration of vitrification. So is live birth affected by the duration of vitrification? There are a study claiming that live birth rate is affected according to the month embryo stays in your lab. I really don't believe that month in nitrogen can really have this incredible effect in live birth rate. And in fact, many other studies did not find evidence that months are associated with live birth. So we decided to make our own study. Let's look if really there is an effect of prior duration has an impact on live birth. And we were surprised to see that in fact, this is in days, 60 days or 100 days or 360 days were associated with a lower live birth rate. But then 2 years or 3 years were associated with a better live birth rate. This is a typical example when you don't correct for confounders. So why in few months time we had this decrease in live birth rate? But because these were first choice embryos, and when the patient is coming back early, it means that she did not get pregnant and she's coming back for the second and the third embryos. So in fact, when we make the correction per the quality of the blastocyst, we found that, of course, this was only related to the quality of the blastocyst. First choice blastocyst, second choice blastocyst were associated with a lower live birth rate. And this, why it's so high? Because it's second baby. When the patient are coming back 2 years later, it's probably because they were pregnant in the first transfer. And in fact, these are first choice embryos available for the second baby. So please, when we look to the results, really we have to be very careful about the patient population we're talking about, the embryo population we're talking about, and the indication. Why these patients are here and not here is because they were pregnant and they come back for the second babies. So we found very important, as I said, because it's a manual procedure, to constantly monitor the KPIs. And now that we are a big group with different centers, we use this control chart to be sure that the centers are in between the warming limit and they're not outside the control limits and near to a significantly lower survival rate. And as you can see, every month, we collect the data from all the centers and we check that all the centers are in between our control limit for example, survival rate in all site donation program. And as you can see, our limit is between 85 and 97%. We realized that there were a couple of centers that were performing better than the other. And we run there, we look to the protocol, we realized very small difference that were implemented in the other center. And we are reaching, you see, a development, an increase in survival rate by putting together the knowledge of and the experience of different centers. So this is very nice when we work all together. Now, to be more consistent, of course, I am very looking forward to automation. Although today this procedure is available in the market, but still it is a semi-automated vitrification with a higher procedure duration, less staff convenience. So we are not yet there, but pay attention because soon it will come in our labs. So I will conclude saying that vitrification is a game changer for our lab with incredible improvement in survival rate for any stage of development, with new timings for vitrification according to the needs of the patient, or the needs of the cell and the development stage of the embryos, new flexibility of the lab that has really changed the picture in the clinic, improving quality, safety, and flexibility. And this is very important when we talk about a multidisciplinary procedure that needs flexibility between different departments, the lab, the clinician, the patient. So this is the way to improve our commitment to the patients. And I thank you very much for your attention, and I look forward for your question later on.
Thank you very much, Laura. That was a wonderful lecture. And as you mentioned, we will answer your questions afterwards, but please, to the audience, you can already start submitting in the chat function right now. So now we will move on to our second speaker, and it's my pleasure to introduce to you Dr. Ludovico Parmigiani, who is going to talk about the universal warming procedure. After a master's degree in biology in 1996 at the University of Bologna, Ludovico Parmigiani completed his PhD in biochemistry and clinical chemistry in 2000 at the University of Modena and Reggio Emilia. He is an ESHRE certified senior clinical embryologist, and he served for the Italian Society of Embryology, Reproduction and Research as a member of the executive committee as well as a scientific director. Lodovico is head of embryology for Next Clinics International, a network of ART centers. He is IVF laboratory director at the Reproductive Medicine Unit, Gynepro Medical Centers in Bologna, and he is advisor for biotech companies. In his career, he has developed and optimized devices and methods for clinical embryology, and he has published almost 100 papers and book chapters in this field. Lodovico holds an international patent for device and method for sterilizing liquid nitrogen by ultraviolet radiation, and he's founder and CEO of N-Teralizer, an innovative startup in Italy for research and manufacturing of sterile gases for healthcare and food production. Lodovico's current research interests are cryobiology, gamete selection, and micromanipulation. And he's editor for many international scientific journals. So now it's our pleasure to listen to you, Lodovico.
Good morning. Thank you very much. It's an honor for me being here. Please forgive me because I'm sick today. So I have the flu. So forgive because probably my tone of the voice is low. First of all, I would like to thank you, Cooper Surgical, for giving me the opportunity to being here for this presentation. I'm always fascinating when I listen Laura, because she has this capacity to tell all the story since the beginning and to describe the science behind vitrification in a very clear way. So I was also lucky to have shared with the beginning of this story. So it's an honor for me. Today I will be focused on a particular niche of vitrification, and so I would like to go straight to the point. I will share my screen.
Excuse me for one moment, please. There's a lab which is not muted. Please, can you mute yourself? Everybody, please mute yourself. Thank you very much.
Okay, can you see my screen?
Yes, we can.
Okay, perfect. So let's talk about universal warming procedure, a single universal procedure to warm any cell, irrespective of the freezing method. Okay, regarding affiliation disclosure, I think it has been already described my roles and my conflict of interest. So we know that cryopreserved cells are transported between authorized assisted reproductive centers, and as Laura told before, oocytes and embryos are vitrified using different brands of ready-to-use kits. So a universal warming protocol may facilitate vitrified reproductive cell tissue exchange between assisted reproductive centers. We dedicated a decade of studies on this universal protocol. We started almost 10 years ago, and this was the first proof of concept study. At that time, the idea was to try to warm slow frozen oocyte with the protocol that we were using for vitrification. This because in that period, some thawing media were withdrawn. So we would like to give an alternative to our colleagues and to ourselves, because in Italy we started to slow freeze the oocyte in 2000, should be 2006, 2005, and in a very, as a routine. So this was a problem in that period. The idea is that when we have a slow frozen cell, the cytoplasm is vitrified. So this means that by using a warming protocol, it is possible to revive, to warm also slow frozen cells. And the proof of concept was performed on oocytes, because the human oocyte is the most sensitive cell for cryo-injury. So this means if this is possible with this very sensitive cell, this protocol is potentially applicable with any reproductive cell and tissue. The idea was to use the conventional warming protocol, which it is based with 1 molar of extracellular cryoprotectant in the first warming step and 0.5 molar of extracellular cryoprotectant. Laura before described very well that there are different protocols for vitrification. But if we are looking to the thawing, so to the warming kits, we will see that majority, not all the kits in the market, but the majority have this composition: 1 molar of extracellular cryoprotectant in the first warming step and 0.5 molar in the second warming step. This could be sucrose, or in the recent version of kits, trialose. What we observed at that time, that by warming sibling oocyte with a conventional rapid thawing, by using the thawing medium for oocyte, and by using this universal protocol, we observe a comparable survival and developmental competence. So the first conclusion was this procedure was promising to warm any reproductive cell tissue irrespective of the freezing protocols. So as we said before, any basic we can so we in in our articles we try to describe some fixed point to perform this universal warming protocol. This universal warming protocol can be performed with any medium. So with any basic medium, it can be TC 199, HCF, MOPS, PBS, any extracellular cryoprotectant, non-permeating cryoprotectant, such as trialose and sucrose, and any supplement. It can be hydroxypropyl cellulose or albumin, etc. What we suggest to keep fixed is 1 minute in the first step in 1 molar solution at 37 degrees Celsius, and we suggest, when it's possible, to use as volume as possible. Okay, I know very well that majority of lab director can tell that they are obtaining excellent results by using just 1 milliliter or 500 microliters. The idea is to suggest to use 4 milliliters, because this can help to harmonize any protocol by limiting the fluctuation in temperature and osmolarity. Then the second step, as the conventional protocols we are used to perform in our laboratories, because these are similar to any commercial kit, is 3 minutes in with just 300 microliters droplet of 0.5 extracellular protectant solution at room temperature. Then 5 minutes in washing solution, and as we said, can be done with any basic medium. And then the final washing. That's it. Incubation prior ICSI in the case of oocytes or embryo transfer. So after the proof of concept studies, we start to collect data and information about clinical results, because as you can understand, it is impossible to the commercial kits from the brands manufacturing the commercial kits to promote this combined use. Also, because it is impossible to, certify that you can use a towing medium, a warming medium for any cell. So any vitrification kit. So the idea was to produce literature for this off-label use of the warming kits. I know that this was not very well seen at the beginning by some companies, but we did this to allow our colleagues to have literature that can help them in any potential problem related to scarcity of warming kits of a given brand. And I think that this was forward-looking, because we did this 10 years ago, and now in the last 2 years we are experiencing a pandemic, a war that are reducing the exchange of basic material between companies. Anyway, let's consider the science. So in this case, in the first study, we observed the performance by vitrifying embryos with chitozato and warming embryos with chitozato, or in another group, vitrifying embryos with chitozato and warming with sage, vitrifying embryos with sage and warming with chitozato, and then in the last group, sage and sage. And in this case, we did not observe any difference in survival and implantation rates. Then this was the second clinical study, which was performed. The first study was performed on blastocyst. The study was performed on cleavage stage embryos. And in this case, we also considered a situation in which we tested an in-house kit for vitrification and warming. And again, by comparing the combined use of these different vitrification and warming kits, we did not observe any difference in survival rate. This study was performed on donor oocytes. This was performed on 820 vitrified oocytes, which were all vitrified with chitozato, and part of them were warm with chitozato, and other were warmed with Irvine. And again, we did not observe any difference in survival rate, fertilization, blastulation, and implantation rate. So this was the second step of the study that I showed you before, because this was a multi-center study, always on donor oocytes. And what we observed again that the study was performed on almost 2,000 oocytes. Again, survival, blastulation, implantation, and live birth rates were comparable. So I think we, in this set of studies, we were able to demonstrate that at the very least, by combining these kits, which were Sage, Kitazato, homemade, we were based on the receipt of Kitazato, Sage, and Irvine, the results are comparable. So I'm very happy that other groups are starting to investigate about this off-label, and we can considering coming out of this off-label use of this universal warming. I believe that the majority of embryologists that are following this presentation already experienced to warm vitrified blastocyst embryos, which were vitrified with a given brand, with another brand for warming kits that they had in their fridge in that moment. The problem is that we should be able to demonstrate that this is feasible. For this reason, I dedicated the last 10 years to produce literature. I understand that this topic can be controversial, but I always prefer to let embryologists, a lab leader, choose rather than to continue to only follow what the marketing of the brands are suggesting to us. So, in conclusion, universal warming protocol with ready-to-use warming kits, which contain 1 and 0.5 molar of extracellular crab protectant, simplifies vitrified oocyte embryo exchange between different countries. These help us to overcome potential regulatory, commercial availability differences. As we said before, we experienced a problem, if I remember well, 4 years ago with a lack of CE mark for a brand of vitrification kits for some months, and then we were in front of the situation of choosing the kits with no CE mark and another brands with CE mark. So what if we have any problem with survival when warming these embryos or these oocytes? I thought that we needed clinical study to have a proof that can be used for our colleagues to have the proof that this is feasible. So I can say that after this set of studies, assisted reproductive centers can choose the warming kit best suited for the needs depending on price, stock, because I think that you all have a couple of culture medium in your lab that you alternate. This is a good practice for any IVF laboratories, because we don't want to depend on the stock back order and why not do this for vitrification? But you know better than me that you cannot do it if you are limited from the fact that once you have vitrified with one brand, you have to warm with the same brand. So this set of studies were performed to make you free. So we can choose depending on the price, stock, distribution reliability, and we can choose irrespective of the brand used at vitrification. That's it.
Thank you very much, Lodovico. That was a fantastic presentation. And we already have a first question. I would start with the second one, actually, because it refers a little bit to your presentation. So you presented very well that there's a really interesting opportunity for us when warming ourselves and using different kits of different brands. So the question was, this person would like to know the amount of basic solution, equilibration solution, and vitrification solution in oversight vitrification. And also not only the drop size, but also the timing of each step. So in your opinion, Lodovico, what would you recommend?
Yes, my recommendation are usually not very well appreciated by lab leaders and very appreciated by media companies, because I always suggest to use the maximum amount of volume. So this means for vitrification, work with a wells of 300 microliters, and for warming to use 4 milliliters. This is the perfect way to avoid any problem by using different carriers, to work in different conditions, to minimize temperature variation of the environment. And then, so 1 milliliter, 4 milliliter in the first solution, and then 300 microliters on wells for the following washing. This is what we suggest, but I can understand that many lab leaders, many embryologists tell to us that they are obtaining excellent results with reduced volumes. They can continue. My suggestion is that if you are planning to change this and you would like to perform a universal warming, it's better that you follow our suggestions, because if you would like to have a, we say in Italy, we say parachute, so have to be into the scientific reference, this is what we have written. But we have written this because we believe this.
If I may add something,
Sure.
I was one of the embryologists complaining about this a lot. 4 ml is too much, 4 ml is too much. We can ensure osmolarity and temperature also with lower volumes. However, when we were looking to different results in different labs, we have understood that those centers that were using higher volumes, at least 300 microliters and at least 2 ml at warming, were performing better. We're performing with a smaller variation. It's not that you can have 100% survival even with lower volume, but if you look to high numbers and to the stability of the results, volumes are important. At least 2 mLs, we were using 1, but we moved to 2. 4, it's even more, but I agree with Ludovico. More volume you use, more stable will be your vitrification results.
Okay, thank you very much. As we are always discussing osmolality and evaporation, and we try to avoid this, in the equilibration step, we don't have a big volume. And some people sometimes ask if it is possible to cover the drops with oil. there seems to be an interaction between oil and the cryoprotectants, which makes it not feasible. So we should not do that. Could you maybe comment on that? Why is it not possible?
Okay, I try to respond to this question. To be honest, since the beginning, we avoided the use of oil because this is an extra difficulties when moving these very small cells, especially in equilibration, when you have moments in which these are shrinking and recovering. So you have different focus. It is difficult to visualize the cells, and we know very well that we have different focus in different moments during the equilibration, and so the shrinkage and recovery. So using also oil will add problems. So this is just for a practical problem. I can understand that oil can make more stable the culture, but I think that the standard is to use 300 microliters for equilibration. What I suggest, often this is not considered, but what I suggest is that to wash the embryo with the basic medium. The first step should be always a washing of the, so you take out the embryo from the culture, and then at 37 degrees, we always suggest a washing with the basic medium we are going to use for vitrification. So we pick up this basic medium sometimes in the warming solution. This is just a suggestion in order to minimize any, maybe is we say in Italy scaramento. Yeah.
Why not using humidified Petri dish? I mean, if we go back to the early stages of IVF, we use basic medium around the well containing the culture of a cryoprotectant solution. So, and when you cover the dish, it will be 100% humidification. It's not for temperature, but at least it's for evaporation. So in the equilibration step, where it can be minutes and minutes, we use basic medium around the well containing the cryoprotectant. We cover it, and at least we maximize the humidity to avoid evaporation.
This can be an excellent idea. Of course, I'm just describing what we do in the lab. This can be an idea. This is something in which there are some scientists that are working in this direction, especially Gabor Vajta is working on this, and I was lucky to be involved in these studies. Let's see, this can be interesting, yes, and useful.
Yeah, especially maybe in the first step equilibration for all sides, because you start with 20 microliters, so really a very low volume, and you need to keep them for a couple of minutes. So really interesting. Thank you very much, Laura, for this input.
I still suggest 300 microliters.
Yeah, but you need, it's this gradual where you add always. So in the end, you have the 300, but you start with a lower volume. And this maybe so for these first steps, it seems to be really interesting. We have another question regarding temperature for the first thawing step. So thawing solution, is the temperature critical? Is it better to check the temperature in around 37 degrees is the original question.
Sure. We know that warming temperature is probably much more critical than for vitrification. So we need to create this temperature delta, and we should be sure that temperature is 37 degrees, not more, because this can create problem to the cell. Again, the problem is always the same. If we work with a high volume, and it is very simple. We incubate for 1 hour is 4 milliliters in incubator, and once we take out this dish, we have more time with the temperature stable. So it is very simple. So if we would like to avoid any temperature measure, that's it. We just need to work with high volume and we resolve any problem.
So you would believe that the first step in the warming procedure is the most critical step in the whole procedure?
Yeah, sure.
Okay. Now we will come to another topic. It is about the artificial shrinkage in non-PGT embryos. How do you shoot, with a laser between 2 cells, or do you make a tunnel as for PGT embryos? What is the best method for artificial shrinkage?
Yeah, I saw this question. I think it was before the video, because when I project the video, so it's just a very small laser shooting, much smaller than what we use for PGT, touching the very extreme part of the trophectoderm. So the video has been projected, so the video of Elena, and that was non-PGT embryos, and I think it can be very useful to look at it.
Okay, thank you. Do we have further questions? Please don't hesitate to submit. I have another question. Somebody was asking me, actually a good friend of mine, what she recognizes. She uses, she needs to freeze 2PN stages according to the German law. And the 2PNs are perfect, so there's no doubts about the quality. But when they are placed into the equilibration solution, sometimes for some patients, she suddenly can see fragments in the perivitrilene space. And it stays, so it doesn't disappear in vitrification solution, even after thawing these embryos during the whole development. They still show these fragments. Do you know what might be the reason for that?
I mean, the oocyte have very strange morphology. I mean, the idea that an oocyte, a good oocyte, it's a good-looking oocyte, should be abandoned, because we know that the oocyte morphology has a lot of variability, even in donor cycle. Fragment will stay in the zona pellucida when the embryo will hatch, so then will not contribute to the blastocyst formation. If this has really an impact on the quality of the blastocyst, nobody knows, because when we did a systematic review of the literature, there were too few data in the literature to really conclude on that. But probably we should not be so much worried about morphological appearance of the oocyte when it has not really a clinical meaning or a biological meaning. So I see fragment, I see the generated cells, but if you go up to the hatching phase, everything will stay in the zona pellucida and will not contribute to the blastocyst. It's a way, it's like if the embryo would discard things that he doesn't need, and it will not remain after hatching.
Mm-hmm. It is just.
I think, yes, I think that regarding 2PM, she probably can give more information here to us, because this is peculiar of Germany and country, I guess only Germany. So probably this fragment that she is seeing in during shrinkage, if I understand well, can be a feature of 2PNs, because we don't have a lot of experience in 2PN. I can tell this, not in Italy, not in other country, not in Spain. So this can be interesting to be investigated, and this can be a topic to be used for lead science. Mm-hmm. Very interesting. Yes.
Mm-hmm. I think she even has pictures, so if you're interested in, maybe you can exchange afterwards. Okay, thank you very much. We have another question about let me see, what was the next one? In oocyte vitrification, do you follow the protocol regarding time, or do you wait until the oocyte re-expands? So are you strict with the protocol, or do you prefer watching?
Okay, I prefer watching, but I follow the protocol. This means that in Italy we have Saint Thomas that we will be sure to watch what is happening, but we give the 15 minutes for the oocyte for fully recovering, because we can watch at stereo microscope, but what we can see probably is not completed, since we know that we have no negative effect in waiting some minutes more. So what I always have done is to wait 15 minutes after the recovering. The problem is that is when you don't have the recovery in 15 minutes, and this can happen. This can occur when you have low quality oocytes or oocytes coming from old patient, and the suggestion is to wait until it is re-expanded before moving to the vitrification solution.
Mm-hmm. However, this fact that the oocyte has to recover was the principle of the beginning of vitrification. But I know that there are different groups that are working on shorter exposure of the oocyte to cryoprotectant, not waiting the recovery, with excellent results. So I am not sure that it's really needed. We need to, I mean, there are groups that are working on that, because in fact, I could not find a reason why we should wait the oocyte to recover or to go in equilibration with a cryoprotectant. It was a belief that we had at the beginning, but there's some evidence coming up that it's not needed, and we could shorter when the oocyte is not recovering after 15 minutes. It's not that we need the recover, it's that oocyte has a very bad membrane permeability and is not behaving normally. So it's a sign of bad quality oocyte, as Ludovico was saying. But do we need or not the recovering? That's something that is still under discussion.
Mm-hmm. Very interesting. Now we have a question regarding the training and experience. How many oocytes vitrification procedures do you suggest to be executed to validate an embryologist?
It depends on which is your training, which is your protocol of training. Because if you train embryologists with 1-day-old oocytes, I can tell you they survive much better, because the membrane permeability increase. So I saw a lot of centers that are using 1-day-old oocyte, and they say, oh, we have excellent results in the training phase, and then I have bad results in the real vitrification. This is because the model of using 1-day-old oocyte is not the best. It's not the best to use pre-vitrified oocyte, because when an oocyte survives to run one round of vitrification, it has a better survival also in the second round. So you are making a selection of oocytes that are very good survivors. So if the training is done with fresh oocyte, or even if it's at the end of the day, then the training is much more representative of what you are doing, really. I don't think there is an absolute number. There are KPIs that you have to reach. Okay, so you have to reach at least 20 rounds of vitrification. Sorry, my phone is ringing. Sorry. So at least 20 oocyte with more than 85% survival in the oocyte are of excellent quality. It can take 100 oocyte, it can take 50 oocytes.
Depends on the operator. Okay.
Depends, of course, depends on the manuality of the operator. But the most important is that the training is done with real oocyte, are really representative.
Mm-hmm. Mm-hmm. Okay. Regarding warmed blastocysts, would you transfer them the same day, or would you leave them into culture for one more day?
Depends on when. Okay, I don't like to overculture embryos in general, okay? So if you have vitrified expanded blastocysts, you should not keep them too much in culture because these are ready for the transfer. There is a paper showing that if after 1 hour and a half, the blastocyst has not re-expanded, you have very, very low pregnancy rate. So I think that in our lab is between 1 hour and 2 hours, because in real life, you cannot set exactly 1 hour prior embryo transfer, honestly. But what we assess is the re-expansion of the blastocyst. We don't overculture the blastocyst.
Mm-hmm. Okay, and now again, another topic about evaporation and avoiding rise in osmolality. What should be the minimal humidity in a lab during the oocyte vitrification?
Odo?
Well, it is very hard to define this. We know that we should have 40% around of humidity in a lab, approximately. And so this is for all the procedures, I think. I think this is standard environmental condition.
Mm-hmm. Okay, thank you. Maybe a last and very...
As I said before, you can create a higher humidification area inside the dish or inside an area. So it's important to understand. This is really what our fathers were doing 20, 30 years ago. But really, you can use a highly humidified area for vitrification because you don't have oil on the top, while in the other procedure, normally you have oil on the top.
Mm-hmm. Really nice recommendation. We are running a little bit out of time, so maybe one very last quick question. For oocyte vitrification, do you recommend a gradual equilibration stage, or is it possible for a direct equilibration?
We recommend gradual. This is the standard protocol. I don't have any experience with direct, non-gradual vitrification for oocyte. Ludovico, do you have?
Rare experiments, but we always performed a gradual. And now we have to say that in Italy we are reducing the number of oocyte vitrification. So probably now we have to ask to our Spanish colleagues, but I think that they continue to use the gradual equilibration. That's it.
Mm-hmm. Okay. Thank you very much. Any further recommendation or something you would like to give us as a take-home message?
To consider vitrification as one of the most important phases of the IVF treatment. It's not the last thing that you are going to learn. It's not an extra procedure. It's not an add-on. It's a regular procedure. As important as denudation, ICSI, vitrification has the same weight. So.
Okay, yeah. Thank you. Thank you very much.
Yeah. My take-home message is that in the last 10 years, 15 years, vitrification was game changer, as Laura said. Now 70% of the cells we are using in our lab laboratories are cryopreserved. We use cryopreserved sperm and vitrified oocytes and embryos. Probably in the future we will work only with cryopreserved cells, so we should be focused about this. This will be that's the reason why we should be able to understand well how to work, not following the fashion or marketing, but understand well what is important for our workflow, and this is for us and also for the brands understand that this is the market of the future. So we should be very focused on this.
Okay, thank you very much. Thank you, Laura and Lodo, for this really exciting webinar. Again, it was really a pleasure. We enjoyed it a lot. I hope everybody enjoyed it as well. And yeah, I give over to Marcel to close our session. Thank you very much.
Thank you so much for all the participants that you free up some time to join our Cooper Surgical Vitrification webinar. Thanks a lot for the great questions. And obviously a big thank you also to our speakers. It has been again a pleasure, Laura and Lodovico. Your presentations were super clear. I think you were able to provide a lot of insight to all of the participants. And thank you, Cornelia, as well for the great moderation. Again, the session is recorded, so we will provide the link to the recordings to the local Cooper Surgical organizations. You can get this information. We'll obviously also help you to support with any questions that you have in the future on vitrification. Just contact your local Cooper Surgical account manager or clinical application scientist. Thank you again for joining, and I wish you a wonderful day today.
And
Bye-bye.
thank you, Marcel, and thank you to Cooper Surgical and to all of you. Thank you.
Yes, thank you so much. Thank you. Bye-bye.
Thank you.
Bye.